which say success is not final, failure is not fatal, it is the courage to continue the accounts. We will start, inshallah, by a case presentation. A 42-year-old male presents to the emergency department with sharp, pleural chest pain that worsens with deep inspiration and is relieved by leaning forward. He describes the pain as a retrosternal and it has been persistent for the past 2 days. He also reports feeling generally unwell and fatigued. On further questioning, he denies any recent illness or trauma but mentioned a recent upper respiratory tract infection about 2 weeks ago. He has no significant medical history and is not currently taking any medication. So the first question is, what are the key characteristics of the patient's chest pain? I will give you like 50 seconds maybe. I will go back to the case presentation. Think and write your answer on the comments. What do you think? The key characteristics of the patient's chest pain. As you can see, you can like describe the pain, which is like retrosternal or what? The typical characteristic of the patient chest pain. Yes, here I have sharp pleural chest pain. Yes. Worsen with the yes. Yes. Good reflection. So the characteristic of the patient chest pain, as she said, bravo, pleural chest pain worsens with deep inspiration and is revealed by leaning forward. She already answered. What diagnostic do these symptoms commonly suggest? It's a pericarditis. Let's move to the other question. What specific physical exam finding would you expect in this patient? Crackles and wheezing upon auscultation, pericardial friction rub, murmurs heard over the aortic or mitral valves, absence of any abnormal auscultatory findings. What's the specific physical exam finding in this patient? Yeah. Okay. B. Yeah, pericardial friction. So the correct answer is the pericardial friction rub. Which diagnostic tests are prioritized for pericarditis? You can have more than one answer here. Yeah, the majority mentioned A and C. Yeah. So the correct answer is A, C, D, and E. Electrocardiogram, echocardiography, the CRP, and also the cardiobiomarker. An electrocardiogram would be a priority to assess for characteristic changes of pericarditis, such as diffuse ST segment elevation and PR segment depression. The elevated cardiac biomarkers may suggest myocardial involvement. The imaging studies like echocardiographies would help assess for pericardial effusion. What treatment options are suggested for pericarditis? We have A. Non-steroid anti-inflammatory drugs for pain and inflammation relief and colchicine for symptom control and prevention of recurrence, antibiotics for bacterial pericarditis, antiviral medication for viral pericarditis, diuretic for pericardial effusion, beta blocker, or pericardiocentesis for draining pericardial effusion. What are the treatment options? We can have also here more than one answer. We have A, yeah. B, A, B, D. Okay, so the correct answer here we have 2, A and D. We do not use diuretic for pericardial effusion or the antibiotic. We use non-steroid anti-inflammatory drugs like aspirin or ibuprofen for pain and inflammation relief, and colchicine for symptom control and prevention of recurrence. Sorry. Pericardiosynthesis for draining pericardial effusion, and we use it too much in also the tamponade cardiac or a pericardial effusion. So now we will move to the course to understand more about this pathology. And we'll start by a definition. The pericarditis is acute or chronic inflammatory process of the visceral or parietal pericardium. We will start our course, of course, with some pathophysiology to understand more about this pericarditis. So the membrane that surrounds the heart, here as you can see, is called the pericardium for the pericardial sac. It has 2 layers with a small amount of fluid in between the layers, less than 15 millimeter. As you can see here in this image, we have the pericardial fluid, which is less than 15 millimeter and which provides lubrication for the movement of the heart. These layers separate the heart from the rest of the content of the mediastinum, lubrication between the 2 layers, and allows the heartbeat without generating too much friction. There is a potential space between the 2 layers of the pericardium, which is called the pericardial cavity. The 2 layers usually touch each other, which is why it's only a potential space. And due to etiological factor, idiopathic, which means there is no underlying cause, infection like tuberculosis, HIV, Epstein-Barr virus, or other viruses, autoimmune and inflammatory conditions such as a systemic lupus or rheumatoid arthritis, injury like pericardium, for example, after a myocardial infarction or heart attack, open heart surgery. We have also medication, for example, the methotrexate, or we have also trauma. So due to these etiological factors, pericardial cells are injured. As a result, they release a combination of fluid, fibrin, and cells in an inflammatory response. The serofibrous exudates roughen then the two layers and creates friction between them. And as a result, pericardial friction rub occurs. There is often irritation and inflammation of the surrounding pleura and diaphragm tissue, and giving us the pain. For the clinical manifestation, as you remember, we have the chest pain in our case presentation. Chest pain, progressive, frequently chest pain that is sharp and pleuritic in nature. The pain is generally occurs with deep respiration and will lie supine. It is relieved by sitting. The pain may radiate to the neck, arms, or also the left shoulder. One distinction is that the pain from pericarditis can be referred to the trapezius muscle. It is often not relieved by nitroglycerin or morphine. Pain usually 4 to 48 hours before a rub is heard. We have also the main symptom, pericardial friction rub. In most cases, pericarditis is diagnosed by the appearance of the rub, specific hard best at the left sternal border. The sound of the rub can be scratching, gating, crunching, or also squeaking. A three-component rub reflects the heart's movement during atrial systole, ventricle systole, ventricle diastole. We have also the fever, dyspnea and tachypnea, and also anxiety, irritability, and restless occur due to stimulation of sympathetic nerve. For the additional exam, we have the blood tests that show raised inflammatory marker such as a white blood cells, ESR, which mean erythrocyte sedimentation rate, and of course the CRP. We have also the echocardiogram, which show us, as you can see here, saddle-shaped ST elevation and PR depression. Also, we have the echocardiogram that can be used if there's fluid in the pericardial cavity. For the complication, we have arrhythmia. It may be due to irritation of the sinus node, which is located close to the parietal pericardium, atrial arrhythmias, especially atrial flutter and atrioventricular conduction disturbance, pericardial effusion, that means an accumulation of fluid with the pericardial sac is called pericardial effusion. The fluid may be serous, purulent, or hemorrhagic. We have also the cardiac tamponade. It develops as the pericardial effusion increase in size compensatory mechanism, ultimately fail to decrease cardiac output. This can lead to cardiac failure, shock, and also the death. We have here at this image chest X-ray showing a cardiomegaly due to a massive pericardial effusion. At least 200 millimeters of pericardial fluid must accumulate before the cardiac solid enlarge, as you can see here. We have a huge cardiomegaly. And now we will move to the treatment. For the treatment of pericarditis, typically involves non-steroidal anti-inflammatory drugs, NSAIDs, for inflammation and pain relief. We have the colchicine, which reduces risk of recurrence. Management of underlying cause such as viral infection, which is the most frequent, or autoimmune disorder may be necessary. In severe cases, pericardiocentesis to drain fluid or surgery for recurrent or chronic pericarditis may be considered. Close monitoring, of course, and follow-up with healthcare providers are crucial for effective management. Here we have an image that shows the pericardiocentesis. We use it to drain the fluid from the heart. And as a conclusion, and in summary, pericarditis demands comprehensive diagnosis and tailored treatment, understanding its diverse causes, utilizing appropriate diagnostic tools, and implementing effective therapies are pivotal in managing this condition. Thank you for your attention. If you have any question, you can ask.